All right, folks. So we've got this 41-year-old female that had some prior trauma, some surgery for some orthopedic injuries, rehabbing in a rural hospital. Has been doing well, but then has sudden onset of shortness of breath and chest pain this morning, and then gets walked to the bathroom, and while in the bathroom, collapses. And they don't feel a pulse, and chest compressions are begun. This is when the call goes out for the help from STARS, and you are launched. So you arrive and chest compressions are ongoing in this patient. And let's just take a little break and have a discussion as to what actually happens in the case of a pulmonary embolus. So here we've got just represented here, we've got the RV, the LV, we've got this clot that forms somewhere here, it comes up to the heart and goes into the pulmonary artery and then goes into the lungs and lodges somewhere. And you can have them bilateral, you can have them all lobes, you can have a great big saddle embolus, you can have very small peripheral pulmonary emboli that don't cause much in the way of symptoms. So it just depends. Clearly in this case, this was a big PE, at least presenting like a big PE. And the patient collapsed and had no pulse initially. So why? So what happens initially is the clot comes up and lodges somewhere, sometimes in multiple places. And now all of a sudden, this RV's pumping and very little blood flow is getting through to the pulmonary circulation because it's being blocked in wherever that clot is. If very little blood flow is getting through the pulmonary circulation, through the pulmonary artery, very little is returning through the pulmonary venous circulation to the left side of the heart. And pulseless is just a marker of profound hypotension. And we've got a situation where the LV has very little blood to pump out. So the LV will be contracting like crazy, but there's very little output from the LV because it's not filling. There's no preload to the LV. And so they lose their pulse. So what's a compensatory response? So right now we're all sitting around with a certain systemic vascular resistance. In the face of a sudden onset of a situation like this, where there's profound low blood pressure, we will increase our systemic vascular resistance. So the body will do that in response to this, and that may result in the regaining of a pulse. In this case, it doesn't sound like it did. The patient was receiving chest compressions throughout. The other thing that can happen is when you've got obstruction to the RV outflow, our pressure and volume on the right side of the heart increases. There is a septum that runs right down here between the RV and LV, and that septum will get pushed over in this direction into the LV. This will further compromise the ability of the LV to fill and further compromise cardiac output from the LV. So that's what happened likely when the patient initially arrested. Now let's talk about this. So I have up in my second point on the top right, severe obstructive shock versus PEA arrest. Really, in this case, it's just a continuum. So let's think about this. Let's say pick a number. I know there's some controversy out there on exact numbers, but just conceptually, let's say you can feel a femoral pulse down to a systolic blood pressure of 60 millimeters of mercury. So if this case happened and the patient's blood pressure was 59 millimeters of mercury for their systolic blood pressure, we would not feel a femoral pulse and we would call it a PEA arrest. If, however, the pressure was 61 millimeters of mercury, we would simply call that severe, in this case, obstructive shock. PE is one of our causes of obstructive shock, and we wouldn't call it an arrest. So what did our crew do? They came, they threw an ultrasound on the patient within minutes of arrival, and they saw a very well contracting left ventricle. So they asked for the local team to stop compressions, and they started norepinephrine, and shortly after that a pulse was regained. And this makes a lot of sense. Yes, PE is a cause of PEA arrest, but depending on how low that blood pressure, there is some blood pressure. If you put an arterial line in that patient during their arrest, their pressure, the arterial line would be reading something. It's not like there's zero blood getting into the LV. Now that's possible, massive saddle embolus that doesn't go distally at all, and I think that will result in pretty quick death. In this case, the LV likely was getting some blood flow and would be able to generate some blood pressure, but not enough to feel a pulse. So it's a continuum. Severe obstructive shock versus PEA arrest is a continuum. The third point in the top right, I actually think as a result of this patient really didn't suffer a cardiac arrest. The ultrasound proved that. There was pretty good contractility of that left ventricle, and there was a tachycardia, a narrow complex rhythm on the monitor. So I think a better term, a more descriptive term in this situation would simply be a pulseless arrest. As I said, the crew had compression stopped, started norepinephrine, and shortly thereafter regained a pulse. Okay, folks, now let's talk about dead space. So you'll note that in the case, the crew noted quite a discrepancy between the venous CO2 and the end-tidal CO2. So why can this happen in pulmonary emboli or pulmonary embolus? So remember this relationship. We know this relationship now. This is especially relevant to our ventilation CCMCP that involves brain injury. We know that the venous CO2 is the highest value, the end-tidal CO2 is the lowest value, and the arterial CO2 falls somewhere in between. But depending on the physiology, it could be closer to one end. It's hard to predict in an individual patient where that falls. We just know that the venous CO2 and the end-tidal CO2 provide the brackets, and the arterial CO2 falls somewhere within those brackets, but we don't know where. So what happens in a PE? Why do we see this big discrepancy and specifically a drop in the end-tidal CO2? So here's our lungs again. Here's our 41-year-old patient who suffers this massive PE and pulseless arrest, and now we've got her on norepinephrine, and we have a very low blood pressure, but we do have a blood pressure, and we've got very low SATs. What's going on with that CO2? So I've just picked some representative normal values here. You'll see the venous CO2. Normally, everyone listening to this has a venous CO2 somewhere in the neighborhood of 45. The arterial CO2 is 40, and then the end-tidal CO2 is the lowest at 35. And again, these are just numbers, but just so we can conceptualize this. So in all of us who don't have this thing sitting right in our lungs, we are in normal physiology, and at an alveoli level, the CO2 comes in, and then there's just passive diffusion into the alveoli where it's breathed out. And it's breathed out, and our end-tidal CO2 sensor sits right here, right at the mouth, and that gives us a value. And again, for us sitting on this call right now, probably around 35. What happens in this physiology? So on this lung, where there is no emboli, this situation is going to take place. CO2 is going to come in because there's blood flow to each alveoli. It's going to diffuse into the alveoli, and it's going to get breathed out. And it's going to go by this end-tidal CO2. And if we had normal physiology and this clot wasn't present, this number would also be 35, and our end-tidal CO2 would read 35. In the case of this situation, we have no blood flow. So if we go back up here, there is no blood flow, and I'll just draw that here. There is a blockage of blood flow. There is no blood flow going by this alveoli. So therefore, no CO2 is going to be able to diffuse into that alveoli. In the atmosphere, there is 0.3 millimeters of mercury of CO2, about. So let's just call it 0, because for math, it's basically 0. So when we breathe in, when this patient breathes in, we're breathing in 0 CO2. So that is what is going to fill our alveoli. It's going to be 0 over here. The reason this changes is because of diffusion. However, if there's this situation, we're not going to have any diffusion, and that 0 is going to get breathed right back out. And it's going to go by the end-tidal CO2 detector. And if the entire lung were embolized, there's a big clot over here, it would read 0, and we would very quickly have death. Now, in this situation, depending on the amount of lung that is embolized, this will determine how far the end-tidal CO2 drops. Let's just say we've got a 50-50 relationship. So on the exhalation, 50% is coming from this non-embolized lung, and 50% is coming from this embolized lung. Our end tidal CO2 is going to read 35 plus 0 divided by 2. And so it's going to read 17.5. Now our venous is still up in this range. So now we've got this big wide gradient between our venous and arterial CO2s and our end tidal CO2. And in fact, there has been some research looking at the utility of this discrepancy in the diagnosis of PE. But you'll recall the numbers in our case. The venous CO2 was 90 and the end tidal CO2 was in the range of 18 or 19. And that's because this is what's going on in this patient. So recall, dead space is ventilation without perfusion. This is dead space. Dead space results in a drop in the end tidal CO2 relative to the blood values of CO2, versus shunt results in hypoxemia. Dead space by itself does not cause hypoxemia. Just in this situation, this does not cause hypoxemia by itself because no blood is getting through here, so no blood is coming back to the left side of the heart to contribute to our shunt fraction and contribute to hypoxemia. But dead space does cause this fall in end tidal CO2. So dead space is ventilation without perfusion. If you look at it from a VQ perspective, we're going to have a very high VQ ratio. So because we've got lots of ventilation, our alveoli are open, but in the parts of the lung that are embolized, we have no Q. So, and if it is 0, then it's actually going to be infinity. So dead space is ventilation without perfusion. And this is the reason why we see the fall in the end tidal CO2 with dead space ventilation. So the last thing we'll discuss today is hypoxemia and pulmonary embolus. This patient was really significantly hypoxemic on lots of supplemental O2. The SATs were in the high 70s range. So how does PE cause hypoxemia? Let's review what happens with the PE. So here again, representatively, we've got a clot sitting right here in the patient's right pulmonary artery. So all of there is no blood flow going to this entire lung, let's say. Now, of course, it could be sitting up here and it could be just this part of the lung, etc. But for the purposes of this discussion, this lung is not getting any blood flow. This lung is getting normal blood flow. Recall your 5 causes of hypoxemia from your ventilation manual. The only things that apply in this case, potentially apply, are shunt and VQ mismatch. So remember that the venous SATs are roughly 75% in us, so we'll just use that number as a normal value, but 75%. So blood comes back to the right side of the heart with a saturation of 75%. In normal physiology, it goes out to both lungs through the capillaries that are beside the alveoli, and oxygen diffuses down from the alveoli into the capillary, and it comes back to the left side of the heart at 100%. Okay? So in this case, that is exactly what's happening in this lung. So in this lung, we have no obstruction. The blood is coming in at 75. Oxygen is being breathed in and it's living in the alveoli, and it diffuses into the blood here and it comes out at 100. However, on this lung, we have no blood flow. So of course, this is going to be times 1 billion, or however many alveoli are in the right lung, but there's going to be a blockage right here. So it's going to come in at 75, but representatively, it's going to stop right here, and there's not going to be any blood flow. If there's no blood here, there is no ability for oxygen to diffuse from here to here and get back to the left side of the heart. So if this was the only situation, the patient's SATs would actually be 100%, because this blood is coming out the pulmonary artery, but it's being stopped right here. So it is not getting back to the left side of the heart to be measured by your SpO2 monitor and to contribute to this equation. The only blood that's getting back to the left side of the heart is the blood that is allowed to flow. And it's going by the alveoli over here and being oxygenated normally. There's nothing wrong with the alveoli over here. They're wide open. If blood could flow by here, it would get oxygenated. But again, blood gets blocked right here. And because it's blocked right here, it can't get back to the left side of the heart, so it doesn't contribute to this. So the SATs would be 100%. But this patient's stats were clearly not 100%. How do they get hypoxemic? So there's a couple mechanisms. So if you look in the top right here, intrapulmonary shunt. No, the patient does not have an intrapulmonary shunt with a PE. They do have dead space, and that was what we just talked about. And that's why we'll see a fall in the end-tidal CO2 because of this. But this does not result in a shunt. Remember, shunt is no ventilation with perfusion. So typically it's blood, pus, or fluid within our alveoli. In the case of a pulmonary embolus, there's nothing in our alveoli. There's no blood, pus, or fluid in the alveoli. The problem is in the pulmonary circulation. So it's not an intrapulmonary shunt. Let's leave extrapulmonary shunt to the end and let's talk about VQ mismatch. So what happens? All this blood that does get ejected into the pulmonary artery from the right ventricle and gets blocked here does get redirected. The blood flow still happens. So it actually goes to the non-embolized parts of the lung. And that results in a larger Q, higher perfusion to the non-embolized parts of the lung, which results in a lower VQ ratio. A lower VQ ratio is VQ mismatch, and a lower VQ ratio is a trend towards shunt. If you have 0 V, that's the lowest VQ ratio you can have, that is full shunt. But a VQ ratio that simply falls is a trend towards shunt, and that can contribute to hypoxemia. So that's one mechanism. Let's think back to this case. Now, I didn't tell you, or maybe I did, I can't recall, but this 41-year-old female recovering from her orthopedic injuries has this sudden onset massive PE. She gets transported to the tertiary care center from the rural site, and she's subsequently diagnosed with a massive stroke. How does she have both? The other way PEs can get hypoxemic is through an extrapulmonary shunt. There's a foraminal valley right here that is part of our fetal circulation that closes off in most of us. Almost all of us, it closes off. However, in a significant proportion of the population, maybe somewhere around 25%, it has the ability to open, so it closes off this way. And the left atrial pressure is much higher than the right atrial pressure, so it keeps the door closed. However, in 25%, and it's something like that, of the population, it's not completely fused. And if the right atrial pressure gets high enough, it can push that door open. And then right atrial blood can go directly through that open door, through that patent foraminal valley, into the left atrium, and then get ejected out into the aorta and into the systemic circulation. So if this patient had residual clot distally, we know she had a pulmonary embolus. If she was one of these 25%, for sure, with the size of her PE that she had, she's going to have right ventricular pressure and volume overload. That pressure is going to be transmitted to the right atrium, and that could open the door. And now she's got a patent foraminal valley, and it's not closed, and any blood coming from the periphery here and coming back to the right side of our heart could directly go over here. And how does that cause hypoxemia? Well, again, we'll use 75% as our normal value. That blood's going to come back at 75%, but it's going to go directly over to the left atrium at 75% because it's not going through the lung and getting oxygenated at all. And now it's going to contribute to this equation. So any blood that does go through the lung and come back to the left side of the heart is coming back at 100. But in the case of a patent foraminal valley, a significant proportion of the blood is not coming back at 100. It's coming back at whatever it came into the right side of the heart as, and in normal people, that's 75. That number is going to be is going to be lower in our sicker hypoxemic patient population. So now we can see why this could cause hypoxemia. So that's a summary of how PE causes hypoxemia. It generally doesn't cause an intrapulmonary shunt. Now, I will add the provision that PE can cause some atelectasis, and that can actually result in shunt physiology. So there can be a contributor of intrapulmonary shunt, but primarily the hypoxemia is through VQ mismatch, as we discussed here. And when the right-sided pressures are high enough, in about a quarter of the population, that foraminal valley opens up. That can certainly contribute to hypoxemia. And we see this. We see really variable degrees of hypoxemia in pulmonary emboli. And I have a very vivid case in my mind of a patient that that died from a massive PE that we transported from south of the city. And the lowest SAT was like 90%, but she died a hemodynamic death. And we've discussed that in the beginning part of this video as to why their hemodynamics are so profoundly affected. So that's it. That's PE. We summarized, we talked about sort of cardiac arrest and obstructive shock being on a continuum. We talked about dead space ventilation and why we might see a fall in the end tidal CO2. And now we've discussed hypoxemia in the setting of PE. Thanks very much. Hey folks, just to tie up one last loose end. We explained, and I'm just going to draw the peripheral clot that's somewhere sitting in the legs or in the IVC or somewhere down there, and will be represented here. So we talked about how the patent foraminal valley can contribute to the to hypoxemia as deoxygenated venous blood gets direct access to the left side of the heart and then gets pumped out into the aorta. What I didn't tie up, again, this patient in this case had a massive stroke. So this blood will certainly flow across this patent foraminal valley, but any further clots that are coming from the periphery and coming to the central circulation and to the right atrium could potentially get direct access to the left atrium. From there, they go into the left ventricle, and then they go into the aorta. And certainly, if they go up into the carotid circulation or the posterior cerebral circulation, the vertebral circulation, they can cause stroke. And that, in fact, is what happened in this case. So I would not be surprised one bit if this poor patient that we're discussing actually was one of the 25% and had a patent foraminal valley. And that would have explained her very significant hypoxemia, as well as the subsequent diagnosis of stroke that she received once arrived at the hospital.